or discussed regarding the basic life support. So here we are going through the pediatric advanced life support. So up. Okay. So whenever we see a pediatric patient, either in emergency or in the ward or in the ICU, so we have to do some initial assessment. So in the initial assessment, we have to look the appearance, the work of breathing, and the color of the child. So based on that, we have to see if the child is unresponsive or if any immediate intervention is needed. So if the child is not unresponsive or doesn't need any immediate intervention, then we'll just keep some supportive management. But if the child is unresponsive, then at first we should call for help from the whoever is nearby. And then we have to, in the meantime, we have to see whether the child is breathing or not, and also check the pulse. Then if the child is not breathing or if there is gasping, then we have to see the airways, provide rescue breaths, administer oxygen, and pulse oximetry has to be monitored. And if the pulse rate is less than 60, then immediately we have to start CPR. So this is just a brief, and we'll go in depth of few of the things. Okay, so in the assessment part, we have initial impression, then primary assessment, and lastly, the secondary assessment. So in initial assessment, what we see, the appearance, which we have already discussed in brief. So here, we can see these are the things which points towards requirement of immediate actions. We have to see if the patient or the child is limp or not interactive, looks very listless, and weak cry is there. So these patients will require immediate interventions. Otherwise, we can go through the routine care and management. Then we have to look for any, then we have to assess the work of breathing. In work of breathing, we have to see if there is any airway sounds, like stridors, like snoring or grunting or wheezing. So these airway sounds tell us that there might be some kind of airway obstruction. Like we can find stridor and snoring in case of upper airway obstruction, and grunting and wheezing are mostly seen in the if any lower respiratory involvement is there or any obstruction is there. Then we have to see if there is any accessory muscle use, and we also have to see how the child is being positioned. Accessory muscles are like from the face, if we see if there is any nasal flaring, that points us towards that the child is using accessory muscles, and nasal flaring might be there. Then we have to see if there is any suprasternal retractions are there or not. And then also we have to see if there is any head nodding, like the patient may nod the head while taking breathing. After that, we also have to see if there is any intercostal or subcostal retractions. So this will point towards that if the child is having any respiratory distress or respiratory failure, so they may start using the accessory muscle, and we need to start immediate action for these patients. Then comes your circulatory status or the color. So severe pallor may be a sign of any acute hemorrhage or any acute bleeding. Cyanosis might be there if prolonged hypoxia is there. So these are the things which you need to assess in the initial status. After assessing these things, we have to go through our interventions. Like in the first slide, we have seen that if the child is unresponsive or any of this, if there's any breathing difficulty or any airway obstruction is there, then we have to go for the with the sequence which is shown in the slide. Then after initial assessment, we'll go through our primary assessment. The initial in initial assessment, suppose if the patient comes to us, any child who is unresponsive, then immediately first thing we have to do is put on the patient with oxygen, and then we have to assess the heart rate or the pulse we have to see, and also have to see the color. So if the patient is very much pale, or there is no heartbeat, or breathing is not there, then we have to see any other signs of life is there or not. And if the patient is having some heart rate, pulse is there, but not having adequate breathing, or patient is gasping, then we have to start CPR immediately. If the patient is unresponsive and has a good heart rate and stay breathing normally, then we have to find out what are other causes. Like there could be hypoglycemia, or in subsequent slides we'll show you what are the causes which can cause those kind of things. In primary assessment, we'll look about the airway. We have to see whether the airway is patent or not. We have to, for airway management, we have to put the patient in a sniffing position or jaw tilt maneuvers we have to do. And also we have to see if there is any obstruction in the airway. And then next thing is, next assessment is breathing. We have to see the breathing respiratory rate, whether there is gasping breathing, whether there is hypopnea, or whether there is tachypnea. Then you have to see the efforts we will see with the if there is any use of accessory muscles. Then we have to auscultate and see the lung sounds, and pulse oximetry has to be measured. Then after this, after assessing the airway and breathing, we'll assess the circulation. Circulation, the skin color and temperature we have to see. If there is acute blood loss, then again we may see the patient coming to us in severe pallor, and if prolonged hypoxia is there, then we may see cyanosis in the patient, and the temperature may be very low if there is any hypothermia, which will suggest that the circulation has been impaired. Then we also have to see the heart rate and rhythm, and blood pressure has to be assessed, and as per appropriate percentiles, we have to see whether patient is in hypotension or any hypertension is there. And peripheral and central pulses has also to be assessed. And capillary refill time, which is normally less than 3 seconds, that one also we have to assess in the peripheries, like in the nail beds we can see that much. And then for disability assessment, we have to see the GCS, the Glasgow Coma Scale, or the ABPU scale. And this pupillary light response has also to be assessed. Hypoglycemia we should also assess with the help of this glucometers in the bedside. And lastly, the exposure. Also, we have to see if there is any precipitating factors for hypothermia, like any cold clothes are there, or any wet clothes are there which has been wrapped with, or any evidence of any lacerations or any trauma is there which can cause blood loss, and those has to be properly draped and managed adequately. After this, we will go through the secondary assessment, which is with a mnemonic sample. Signs and symptoms we have to see: allergies, medications, any past history, and any last meal taken, and any other known events that has led to the current illness. So when you see any patient lying down, any child, either in the emergency or in the ward or in the ICU setup, we'll just initially see for the breathing. Then if there is no breathing at all, or if there is gasping breathing, then we have to see if there is any pulse is there or not. If pulse, we have to see for at least 10 seconds. And in the 10 seconds, if we find pulse, and if it seems less than 60 per minute, then we have to start immediate CPR. Or if it is more than 60, then we may just start with simple positive pressure ventilation with bag and mask. So these are the things. In a step 2, the positions has been shown. This is 2-finger technique, which is put just above the sternum for giving chest compressions. Then this is the third step, which is shown here, is the jaw thrust maneuver, where patient's airway, the rescue giver has tried to open the airway and keep it patent. Then this is how mouth-to-mouth breathings are given. Then this is all we have already discussed. The important things which we need to discuss here is when there is a single rescuer is there. At that time, the CPR rate, which is CPR rate should be 30:2. That means for every 30 compressions, we have to give 2 breaths in case of a single rescuer. And if double rescuers are there, then after every 15 compressions, we have to give 2 breaths. Okay. So these are some common treatable causes of cardiac arrest. So whenever a patient goes into cardiac arrest, we have to look for these common things. Like if any hypovolemia is there because of any blood loss or any intercurrent illness which is causing severe hypovolemia in the child. Any hypoxia or acidosis, either respiratory acidosis or metabolic acidosis, or disbalance in the potassium levels and hypothermia. So at least from our side, before this hypokalemia or hyperkalemia may not be assessed immediately, because this will require some laboratory assessment, either blood gas or serum electrolyte assessment. But hypothermia will know by just simply touching the child. So these common things has to be taken care of initially. Then other things like cardiac tamponade, pneumothorax, pulmonary embolisms or coronary embolisms. These are other causes which can also cause cardiac arrest in the child. So this is the pediatric cardiac arrest algorithm, which was recently updated in 2020. And there are not much changes as per the 2015 guidelines. So once we start giving CPR, we also should initiate bag and mask ventilation. This bag and mask ventilation, we have to provide 100% FiO2. Like as we know that when we are using a EMBU bag, there we have to connect with the oxygen in one port, and in another port there is a reservoir port is there that has the reservoir has to be connected with that. So this will provide around 95 to 100% of FiO2. So apart from that, in the meantime, we will some of our the other rescuers also should put the ECG monitoring, put the ECG leads and start to prepare for the ECG monitoring. Then we have to see if the patient's the rhythm is shockable or not. So shockable rhythms are ventricular fibrillation and ventricular tachycardia. Then the non-shockable rhythms are asystole and pulseless electrical activities. So if there is shockable rhythm, then we have to give a defibrillation. We have to give a shock, and that one should be 2 joules per kg in the first shock. Then subsequently, we may need to double the doses. So after giving the first shock, we have to again continue for CPR for 2 minutes. And in the meantime, we also should have IV and intraosseous, IV or intraosseous access, whichever is possible at that time. After 2 minutes of uninterrupted CPR, again, we'll see whether how is the rhythms in the ECG monitor, which we were been monitoring. And if again patient is still in cardiac arrest and the rhythms are shockable, then again we'll continue with the second shock and start giving epinephrine. So after second dose, again we may need to go for a third times of the defibrillation. And even if that patient doesn't get recovered, then we may use some medical management like amiodarone or lidocaine. Okay, so this is it in brief. So here a simple slide is shown where 30 breaths are given with 2 rescue breaths. 30 compressions are given with 2 rescue breaths. So that means only a single rescuer is being there in the resuscitation. So here are the two images are shown. Can you look over the images? Here the rescue caregiver has tried to give chest compressions with the help of two fingers, and the two fingers should be placed just above the sternum, just above the sternal notch. Sorry, sternum. And the ECG leads are being placed for monitoring of the rhythm, and this is a hambo bag. When there is single rescuer, we have to give 30:2 this one CPR, 30 chest compression and 2 rescue breaths. So either we can give with 2 fingers, or either we can give with this one with 2 thumbs. And if you are using 2 thumb technique, if we are giving if 2 rescuers are involved, then this 2 thumb technique is preferred as compared to the this one double finger method. And if a single rescuer is giving, then he can use either one, whichever is comfortable with that. Then this is this is what is shown in this figure: chest compression in an adult, in a child, and in an infant. As we can see that the rescuer is using the 2 finger technique, we can also use the 2 thumb technique. Then if suppose the infant, we are not, if the rescuer is very young, or is not able to raise the baby's sternum appropriately, then he or she may also use the 1 hand technique for giving chest compressions. And so here it is shown that how a child is receiving chest compressions. So this adult and pediatrics cases, how to differentiate whether to start chest compression as like adult or as like children. We have to see for the signs of puberty. If any signs of puberty are there, then we'll give chest compressions as like we give in the adults. And if signs of puberty are not there, then we'll follow the pediatric guidelines. So here are the few important things which we're going to discuss in this slide. So how many chest compressions should be given in 1 minute? So it is around 100 to 120 chest compressions to be given in infantile children in a minute. And it is a rate of compression. And how much deep we should push the child, how much deep we should compress the child. That is at least 1/3 of the anterior posterior diameter of the child. And in case of adults, it is around 5 centimeters. So that is a thing. And after each chest compressions, the rescuer should allow the chest to recoil completely. We should not just simply push and not allowing the chest recoil will hamper the quality of our CPR. So again, this is at number 6 point, we can see that the rhythm check has to be done after every 2 minutes. It's not that after every 30 seconds or within 1 minute of giving CPR, we are starting to assess the child. At least for 2 minutes of CPR, we have to give and then assess the pulses for at least 10 seconds. So this is the things which, and few other things, so we have already discussed. This number 9 is another important thing. So during the CPR, sometimes people get confused to whether give 15:2 respiration in case of an intubated patient. So whenever patient is not on any advanced airway means patient is not on any endotracheal intubation or any tracheostomy tube, then we have to give 15:2 or 30:2 as per the number of rescuers. But whenever a patient is already having an advanced airway, like in case of those patients who are in the PICU or those in the ward home already intubation has been done. So in those cases, the rescue breath should be at least 1 breath in 2 to 3 seconds, which is around 20 to 30 breaths per minute. So in that time, there may be dysynchrony of this 15:2 ratio. And the chest compressions will continue with 100 to 200, 120 compressions per minute, even either in advanced airway or if the patient is not having any advanced airway. So next, suppose if we diagnose, if we see a patient in bradycardia, which is usually considered if the breaths as per the age-based criteria. So we have to see any cardiopulmonary compromise is there or not. Like if any, we have to see the mental status of the child. If the patient is having a altered mental status or very much drowsy, very much lethargic, and any signs of shock is there or not. If the patient's BP is very low. So if these things are there along with bradycardia, then at first we have to again maintain the ABCs. ABC means airway. Then we have to see whether it is patent or not, or if any obstruction is there. Then we have to see the breathing status of the child, and monitoring has to be done. After that, if we have to see the heart rate, if it is still less than 60 per minute, despite of giving oxygenation and proper ventilation, we have to start with CPR. And as we have mentioned before, that we have to continue CPR and see the rhythms, whether the rhythms are shockable or non-shockable after giving 2 minutes of CPR. If the patient requires any defibrillation, then we have to follow the cardiac arrest guideline again. If there is heart rate but still less than 60, and then we have to start giving inotropic supports like epinephrine and or atropine. And in the meantime, we have to see for any treatable causes is there or not. If treatable causes are there, then we have to start treating the child. So here are doses which are being mentioned here, which we use regularly in the ward or ICU in case of the emergencies. The dose of epinephrine which is used after dilution is 0.1 ml per kg. If the patient is 10 kg weight, then we may use 1 ml of epinephrine. Then next is your pediatric tachycardia management. Here also it is similar with that bradycardia algorithm. We have to assess the ECG in the monitor. Either we have to print out an ECG or we have to keep monitoring in the monitor. And then we have to see what kind of tachyarrhythmia it is there. It is sinus tachyarrhythmia or it is non-sinus tachyarrhythmia. And the other parameters also has to be assessed accordingly. So this is a maneuver shown when there is any obstruction or any foreign body is there in the tracheobronchial tree. So this is in case of infants, we can make the infant lie in a prone position in our hand and give gentle tapping in the back of the child. So if there is any foreign body or any other things causing the obstruction, then it may come out from the airway after giving this, after putting up in this maneuver. So this is one more picture which is showing that if any foreign body or any other obstruction there in case of toddlers or any children, then pressure can be applied just above the umbilicus in the abdomen and gentle thrust should be given. So this is regarding management of foreign body. Then after managing the child in the acute setting, after correcting the cardiac arrest, after when the patient comes out from the cardiac arrest, what other things has to be done. So this is our post-resuscitation care. After resuscitating any child, we have to keep maintaining the airway. And in airways, we have to see for any how is the oxygenation. This oxygenation levels can be assessed with the help of blood gases. The partial pressure of oxygen, saturation level, these things can be assessed with the help of ABG. And ventilation monitoring can be done if there is any CO2 retention or CO2 washout that can be shown in our CO2 ETCO2 monitor. Then in the meantime, if any patient either after cardiac arrest or those patients who are already been ventilated is having persistently desaturation or the saturation is dropping along with bradycardia. So at that time, we need to think of the new acronym DOB. DOB stands for displacement of the tube, if O for obstruction of the tube, and P for pneumothorax, and E for equipment failure. There is so many charts out there. Later on now only. So these things has to be assessed. So in case of displacement of the tube, we may need to reinsert the tube. If there is any obstruction, we may need to do suction or again reassess the tube for tube functioning. Then for pneumothorax, we need to put an ICD in the patient. And for equipment failures, we have to see whatever failure is there, we have to tackle those equipment failures. And arterial saturation, oxygen saturation, usually we need to maintain it 94 to 99% in case of patients who are having who already had cardiac arrest in the immediate cardiac arrest period. Then we should also avoid recurrent shock by regularly assessing those children. And temperature control is also an important thing, and blood sugar management. So these are the important things which you need to do after doing cardiac CPR or post recovery from a cardiac arrest. Because if you don't care regarding these things, then again patient may go into recurrent cardiac arrest. And if any patient is having recurrent cardiac arrest, the mortality and the morbidity increases in the subsequent cardiac arrest episodes. So these are the things, and few things which I have not mentioned here, and because of time constraints. And there are questions which are being asked, like for how much duration are we going to continue our CPR? So I've gone through the guidelines. There are no any specific time limit for continuing or discontinuing the cardiopulmonary resuscitation. Some patient may revive even after 40-45 minutes of cardiac arrest also, and which has been seen in case of like poisoning and all. Or there's a thing, and the continuation or discontinuation of CPR has to be assessed by the rescuers, those who are giving CPR, and with the attendants or the parents or whoever is there with the patient. So this is some basic outline of advanced cardiopulmonary resuscitation or advanced life support. So there are many other things that can be discussed, but most important thing in this topic is our this one, practical skills and practice in mannequins. So even if we study for the whole day regarding this advanced life support without our practical skills and practicing in a mannequins or in a real life scenarios, it is very difficult to understand the things. So I hope this much will be helpful for everyone. And if any queries is there, you can put up the queries.
Thank you, sir, for this wonderful session. So I request the participant to kindly unmute themselves and ask question. Yes. So there is a question. Iris has written, sir, if a patient is already on ventilator and develop cardiac arrest, how should we approach, and do we need to disconnect the ventilator and do CPR on, or how should we do? So you have
Okay.
asked the question.
So thank you for the query. If the patient was already on ventilator and we are seeing the patient is having cardiac arrest, so at first, how we know that patient is having cardiac arrest? We may see the patient is starting to have desaturation and patient's heart rate is dropping below 60. So at the time we know that the patient is going to cardiac arrest. In those cases, we have to disconnect the ventilator and put rescue breaths with the help of an ambu bag. And if still after giving appropriate breaths with the ambu bag for at least 30 seconds to 1 minute, we have to see the cardiac monitor. If even after giving this one respiration with the ambu bag, the heart rate is not improving, then we have to start on giving CPR. And CPR, as we know that if 2% are there, mostly in case of ventilated patients, that means the patient is already in ICU. So we expect that patients, will have at least 2 or more than 2 rescuers will be having. So at the time we can follow the 15:2 this one. Chest compression and breathing sequence. So one important thing here we should know is that monitoring we have to continue only, and in these cases who are already intubated or having tracheostomy or either endotracheal tube, we after giving these breaths for at least 20 to 30 breaths in a minute, if the patient's saturation is not improving and heart rate is still less than 30, we have to start chest compression at least 100 to 120 chest compressions per minute. After 2 minutes, again, we have to assess whether the heart rate is improving or not, whether the saturation is improving or not. If these things are adequate, then we may reconnect the patient with the ventilator. And even if the patient is not improving, after giving chest compression for 2 minutes and chest compression and breathing support for 2 minutes, then we may need to start giving this one, epinephrine for the patient. And then these things every 3 to 5 minutes, we have to repeat and see if they're still not improving, then we may continue giving epinephrine every 3 to 5 minutes like that. Then kindly explain the ABPU scale. ABPU scale means alert. If we have to see, ABPU means alert, verbal, pain, and unresponsiveness. So it is more simpler than the GCS scale. So in GCS scale, we have to see for eye response. There we have again E1, E2, E3, E4 we have. Then again in the verbal we have again 5 components. Then again motor we have again 6 components. But in ABPU scale, it is just 4 things only. Just one thing only you have to see. On appearance, we have to see whether the patient is alert or not. After that, we have to give. If the patient is not alert, we have to give verbal commands like get up from the bed or do this and that. And if the patient is still not responding to the verbal command, we have to give pain stimulus. Then you have to see any motor movement is there or not after giving pain stimulus. Patient is opening the eyes or not, patient is moving the limbs or not, we have to see. Even if after giving pain stimulus, the patient doesn't respond, that means we consider is the U in the ABPU scale. U means unresponsive, like that. So, but the guidelines for intubation and all is according to the GCS scale only. If less than 8, then elective intubation is warranted. And if the patient is GCS is between 8 to 12, then we may need to put on supplemental oxygen and continue monitoring the patient, and RBS and all these things has to be seen. Then next is what? Sir, what is the exact position of hands to be placed in the sternum? See, while giving chest compressions, our main aim, why do we actually give chest compressions? We, by giving chest compressions, we want to push the heart, we want to pump the heart artificially, as in a normal patient, because of this neuromuscular coordination and all, the heart usually pumps by itself. So whenever there is cardiac arrest means heart has started to slow down or started stopping. So in those cases, we need to give chest compressions. And chest compressions, the idea of giving chest compression is we have to put a pressure in the sternum, and in the lower side, there will be our vertebra. So the heart will get compressed between the sternum and the vertebra. And that is the main purpose of giving chest compressions. And the position of the thumb or the finger should be just above the giphisternum, at least at the level of the mammary line, the intermammary line, just below it. We have to push the, put the pressure.
Loading dose of epinephrine.
So for every patients, we have to like the most commonly what we use is not most commonly, the recommended drug is epinephrine in case of giving CPR. So the dose is after diluting 1:1000. That means 1 ml of ADR we will dilute with 9 ml of NS and make it 10 ml. And after that, we'll give it 0.1 ml per kg of epinephrine. Suppose if the patient is 10 kg, then the adrenaline which we have, the diluted adrenaline, will give 0.1 into 10, which is 1 ml, like that.
Another question is abdominal thrust in children, from which age?
So those patients, this question was asked on the basis for
Remedian Suting has asked a question. Yeah.
So this thing, there is no any proper guideline, like there is some appropriate age or what. If the patient is not an infant means less than 1 year of age, whom you cannot put under a palm or in the thumb, in a palm. Those patients you may start giving this abdominal thrust. And when the patient is able to walk or at least 2 years of age, then those patients we can start giving this abdominal thrust. Otherwise, we can put in the palm and start giving this one back tap in these patients.
There is another question. Can we use atropine for infants?
See, for resuscitation, we use epinephrine, the drug of choice for this one. And in resuscitation purpose, we use epinephrine. Atropine is used only if there is bradycardia, persistent bradycardia is there. Those patients only we can use atropine. But atropine is not a drug which is okay. So one question has been asked, a patient is already on adrenaline. Should we give injection adrenaline in 3 to 5 minutes? So the patient who was already on adrenaline was on an infusion dose. That is not a bolus dose. So what we do is we give boluses every 3 to 5 minutes. There is an iron drop which will stimulate the heart to beat faster.
Thank you, sir, for answering the queries. I request other participants, if you have any queries, so kindly write in the chat box. Someone has asked to please repeat how deep compressions should be during CPR for newborn.
Okay. So in pediatric patients, we give chest compressions of at least 1/3 of the anterior posterior diameter. That means, suppose a patient is lying down. Can you see me? I think you can see me. So this is the back of, suppose in my left hand, I can show you, this is the back of the child. And this is, suppose where I'm putting the hand is the chest of the child, the anterior part of the child. So we have to assume how much will be their depth from the chest to the back of the chest. And from there, we have to assume how much will be their 1/3 of the anterior posterior diameter. Anterior posterior means anterior from the chest to the back of the chest. So that is the anterior posterior diameter. So in that diameter, at least 1/3 should be compressed. In infants, it is usually 1.5 to 2 centimeter, and in children, it is around 3 centimeters like that. In adults, we have to give at least 5 centimeter of chest compression. Someone has asked, what is the indication of adrenaline infusion? So we adrenaline which we use during the resuscitation is a bolus dose of adrenaline. So that is to resuscitate the child while doing CPR. And infusion we use when the patient is either in shock or post cardiac arrest status. After resuscitating the patient, when the patient got revived, or there is return of spontaneous circulation, like ROSC, which is a short form. So after the patient comes to, when the patient has return of spontaneous circulation, at a time to maintain the cardiac activity, we have to start adrenaline infusion. The dosage which is 0.1 microgram per kg per minute to 1 microgram per kg per minute, like that. We have to start adrenaline infusion. If the patient is on ventilator for longer period, do they advise for tracheostomy for infant? Yes. So there are some assessment which we need to do before putting a patient on tracheostomy. Like if we, because of some prolonged illness, either due to respiratory or due to neuromuscular illness or any neurological illness, in which patients we assume that the patient may require prolonged duration of ventilation, those patients we may put on tracheostomy. Because if you put a patient on tracheostomy, the dead space also gets reduced and there is lesser chances of infections and all. Okay, so someone has asked, sir, please explain asystole. Asystole means there is no any pulse. We cannot feel any pulse. We cannot feel either in the periphery or either in the peripheral vessels or either in the central vessel or either in the heart. We cannot feel any pulse or we cannot hear any heart sounds. And there is no any electrical activity shown in the monitor. So those patients, we will call it asystole. And what is PEA? PEA means when there is asystole, we don't give any shock. And PEA means pulseless electrical activity. Pulseless electrical activity means there will be no pulse, but in the monitor, we can see some amount of electrical activity is flickering above. So those are called pulseless electrical activity. So in case of pulseless electrical activity and asystole, we should not give any shock. That's it.
Sir, there is another question. Abdominal thrust in children from which age?
Yeah, when I said in infants, I have already shown in the diagram. There I have mentioned in case of infants. So infants are already less than 1 year, and those are more than 1 year. Those are not called infants.
Another question is, are there other examples of shockable cardiac arrest other than VT?
Now, one question was asked, are there any other examples of shockable cardiac arrest other than VT? Other than VT, we can have ventricular fibrillations. If there is any fibrillations is there, or ventricular tachycardia, then these patients we can give shock defibrillation.
So another question is, when heart rate is less than 60 per minute and it is not ceased, is FP required or injection adrenaline?
Injection epinephrine and adrenaline are both same only. And this one here, when heart rate is less than 60 and we have already started CPR, there were some previous school of thought that at least after giving 3 doses of ADR, we should not give few people used to think like that, but there is no any specific guideline that only 3 doses has to be given. You can give as much as you think that is required for the resuscitation of the child. And in the meantime, it's not just about giving adrenaline. You have to also see any other treatable causes are there or not. And if treatable causes are there, in the meantime, while giving CPR also, we have to see those causes and start treating those causes. Like if
Yes.
hypoglycemia is there and we are still giving CPR and we are not treating the hypoglycemia, then patient may not revive at the time. So we have to, in the meantime, we have to also treat the hypoglycemia.
What are the pre-medication before intubation?
One is sedation and one is analgesia. We can give in the patients, those who are planning to intubate. But if already the patient is on cardiac arrest, then we have to, before intubation, we can start with giving this one bag and mask ventilation. That is the important thing. In all the pediatric advanced life support guidelines, which was last updated on 2020, they also have mentioned bag and mask ventilation and chest compression is the most important thing which we need to know. If after patient gets revived, then we may start thinking of doing an intubation. And if the patient is already intubated, then we may continue the CPR and rescue bridge. But if the patient is not intubated, there is no point in wasting the time for intubation. Just do chest compression and with bag and mask give breathings.
There is another question. The site for chest compression, is it same for male and female children?
Yes, it is same.
Another question is, if patient is on ventilator and is on sedation and muscle relaxant and had cardiac arrest, do we have to stop infusion or not?
Okay.
So, if the patient is on ventilator and is on sedation and muscle relaxant and had cardiac arrest, do we have to stop infusion or not?
So regarding this, there is no point in continuing the muscle relaxant or sedation for the patient. So our prime objective is not regarding their status of fluids, whatever is going on. Our prime thing is we have to resuscitate the child. For resuscitation, whatever things are there, that has to be our focus. The chest compressions, the breathings, the monitoring, these things. And apart from that, apart from this monitoring, if we need to give adrenaline or whatever emergency drugs, those can be given. And there is no any recommendation whether we have to stop in all other medications while giving CPR or either have to continue. There is no any such guidelines for that. It will depend on the clinician who is doing the resuscitation. And if suppose only few lines are there, suppose we are giving sedation, muscle relaxant with only 1 or 2 lines, and if we need to resuscitate, then we may need to avoid those infusions and use those lines for emergency purposes like epinephrine injection during the CPR.
There is another question. Can we check hyperkalemia with ECG?
Yeah,
Which
hyperkalemia, we can see tall T waves can be seen in the ECG. In ECG, we have PQRS and T wave. So T wave will be more prominent in case if there is hyperkalemia. And if there is hypokalemia, then T wave will be less prominent, or you may get an inverse T wave also, or a U wave also we can see. And QRS complex will be get widened.
There is another question. How to identify pneumothorax in children?
Okay, how to identify pneumothorax in children? In children, we have to do percussion and auscultation. If the child is crying, then it is easy for us if the child is crying, whether pneumothorax is there or not. If the child is not crying, then we can do auscultation, percussion and compare both the sides of the chest and see whether there is any pneumothorax or not. And if it is if still in doubt, then we can do this one. Put a needle in the second intercostal space and see if there is any bubbling or not. So if there is any pneumothorax is there, if we suspect the right side pneumothorax, then we'll put the needle in the left intercostal space and see if there is any bubbling. And X-ray will help us to identify if there is any pneumothorax.
Someone has asked, one-hand technique for compression is used for which age group of child?
There is no any specific age group for using one-hand technique. In case of infants, it is safe to use 2-thumb techniques. If the rescuer or the caregiver is not able to put the thumbs properly or not able to compress adequately, then he or she may start using the one-hand technique. the most primary important thing is, whichever things you do, there should be perpendicular pressure should be given in the sternum, and it should be the adequate compression should be given, like at least 1/3 of the anterior posterior diameter should be reached while giving the chest compression. Even in case of infants, if we are which is in infants, suppose you are using 2-finger technique, but you are not able to reach 1/3 of the anterior posterior diameter, then that quality of CPR will not be effective for the child. So in those cases, you may start giving one hand. And if suppose child is 3-4 years or 5 years, in whom you are not able to give with one hand, then you may use the 2-hand technique also. So that's it. Our prime thing is to give adequate chest compression and high quality CPR.
Yeah, I think there is no more questions. Thank you so much, sir, for taking up the queries.
And one more thing I would like to know from all those staff working here, what is the opinion regarding keeping the patient attenders during the CPR? Like there is no any, I also try to find out if there is any guideline or any recommendations, but there are only few studies are there only. But I just wanted to know from you all if, what is your opinion? If the parents wants to stay during the moment of CPR, should they be allowed or shouldn't they be allowed? Okay, so few things that it should be allowed, and some of the things that it should not be allowed, and these things happen with most of the studies only. And there are few advantages and disadvantages maybe while if we allow the parents or the attenders, because if we allow them during the resuscitation, then if there is any untoward event, then the parents, they'll be easy for them to cope up with the loss or whatever any untoward even event happens. But if we don't allow them, there are most of the time that the attenders or the parents just go into doubt that whether how was the last moments for the patient, whether they were properly seen or not, properly the things are done or not. Those things, those doubt usually gets remain in the patient attenders and all. So, but there is no any guidelines either in the international or the national. There is no any guidelines like whether we should allow them or not. But most of them has recommended that they should be allowed if they wish to stay. And ultimately, this will depend upon the every institutions, whether institution means the institutional guideline.
Requesting the participants to kindly fill the post-test. The post-test link is given in the chat box. There is
So
also
probably, many studies are required, and many this psychological assessments will also be required in the upcoming days, like to formulate a proper guideline regarding these things. So, thank you everyone so much for
much, sir.
presentation. Actually, this was in a very short notice we had to do this thing. I don't know whether it was helpful or not.
No, sir, it was really helpful. I believe